Okay, next up, our speaker is Dr. Kevin Lai from Indianapolis.
All right, I'd like to thank the moderators for inviting me to present and our esteemed panel here for commenting. So I have the distinction of presenting a case on a patient who came in and said, they told me my optic nerves are swollen. So I have no financial disclosures. And so this patient comes in and says, hey, well, my doctor told me that my optic nerves are swollen. Didn't know any problems there. So this is a 17-year-old Caucasian female who 3 weeks prior to presentation had a rapid onset of bilateral eye pain, headaches, and binocular horizontal diplopia, and went to the ER after talking with her primary care doctor, who said, oh, well, you know, maybe it's some main concern there, and they had a CT scan that was read as normal and diagnosed with a migraine and sent her home. About a week and a half after that, the headaches and the double vision improved, but she still continued to have blurred vision. So at that point, she decided to self-refer her to an optometrist who noted optic nerve edema in both eyes and was referred for evaluation. Okay, when she presents to the office, she primarily complains of blurred vision. So a few other things in her history that might be important would be that she complains of constant blurred vision that worsens with bending or coughing, some whooshing type sounds in her ears, but no weight changes and no recent travel, illness, or trauma. Okay, her past medical history is only significant for seasonal allergies and acne. Her rest of her history is really not all that significant, but her medications, I want to note, she is on some allergy medications, including recently stopping a steroid nasal spray and then minocycline for her acne. So on her examination, so she's moderately overweight, but not terribly, and then she's also got normal blood pressure, and her visual acuity and afferent function are normal. Her visual fields initially are full to confrontation, and her anterior exam is normal. So I'd like to first stop here at this image and invite the panel to speak a little bit about the optic nerve appearance and comment on some of the thoughts that they may have.
The nerves are swollen. But importantly, she's got excellent afferent visual function and crossed eyes by report, and this is elevated intracranial pressure until proven otherwise.
I'm bothered by the fact that she presents complaining of blurred vision. As has been spoken about earlier this morning, in general, papilledema doesn't cause blurred vision unless there's significant disc swelling to cause an enlarged blind spot, or the papilledema is caused by an intracranial mass, maybe in the third ventricle or something like that. So I worry about the message this sends to everybody, because I would expect somebody with standard papilledema, if they've got if they complain of blurred vision, I would have expected substantial disc swelling, maybe hemorrhage or exudate in the macular or submacular fluid or something like that. Having said that, I agree completely with Judith. This is papilledema until proven otherwise. The patient doesn't have to be obese to have a pseudotumor picture, but of course, again, if you're going to say this is papilledema until proven otherwise, then you have to say it's a mass lesion until proven otherwise, and then you have to go from there. There are other issues, of course, as well, including the fact that she's treated with a drug that could be associated with increased intracranial pressure, and that's minocycline.
Just to play devil's advocate, these discs are swollen, and I would proceed with a workup for papilledema. The little crescent-shaped hemorrhage next to the right disc, which looks deep to me, that's something I generally favor pseudopapilledema a little bit with. Maybe she could have both swelling on top of it. I don't think you have a choice here but to aggressively pursue papilledema as a leading diagnosis. But I think what the panel is reacting to is that this is not the discs we were expecting to be shown in a young person with a rapid onset of elevated intracranial pressure symptoms. And, this is more like the disc that went to the optometrist for glasses, and they looked in, it's, yeah, I think it's swollen, and there are some discs you just can't tell, and I would proceed in the papilledema direction, but between the hemorrhage, the general appearance of a lot of those vessels as they relate to the disc swelling, and the disconnect between the history, I think there's some room to be not surprised by some zigs and zags in this case, I'd say.
Does the 2015 corrected vision reassure you at all?
I guess it's just a question of why she was complaining of blurred vision if she's 2015, and whether it was just the transient visual obscuration she was having, that, blurred vision, everybody has blurred vision or will offer that as part of their afferent complaints to an ophthalmologist, but there's just, the history isn't perfect for these discs, and that's just the way I'd leave it.
If she's having bad headaches, some people just sort of get a little bit of blurred vision because they're having a headache. Maybe that's it, but it's something that should bother you.
All right, so here are her visual fields that we obtained, which show some mildly enlarged blind spots and some just kind of noise in the total deviation there, so it's a little bit depressed. So I'd like to open up the audience response question here, and so the panel's already alluded to some of this. What would you think is the most appropriate next step in management?
So A would be MRI brain MRV, B, stop current meds, C, lumbar puncture, start Diamox, or urgent surgical treatment with optic nerve fenestration.
Okay, panel, do you have any other comments on that?
I think I'd certainly agree with that, and I think everybody who would see this patient would have to go in that direction. It's a thin patient. The minocycline-associated pseudotumors are more common, and also it's not a patient who's gained weight, but she certainly sounds like she has the setting of being overweight, which in my own experience, I'm not sure if it's true in the studies, is a slightly greater risk factor for the minocycline-induced version of it, but I don't think there's anybody here who would just say, stop the minocycline, lose 5 pounds, and come back in a month. That'd just be too risky for someone who could have a brain tumor.
And I think the other thing is that if you didn't have access to MR, CT and CTV would be just fine as well. Often physicians will say to me, well, my people want to do a CT as opposed to an MRI. And the answer is you should order whatever your hospital feels most comfortable with. So CT, CTV would be pretty much just as good as an MR or MRV. It'll show you what you need to see.
And she had previously had that head CT in the ER, which was probably non-contrast. Would anyone say that that was sufficient neuroimaging and just stop the drug and watch?
If it's a pure CT, first of all, I'd have to see it myself. I don't think you ever, people used to be worried about the demise of neuro-ophthalmology once neuroimaging came in, and what many people say is we spend our time reevaluating supposedly normal imaging studies. So I wouldn't be comfortable with the report that the CT was good, and you certainly may not see venous sinus stenosis with a pure CT.
I think under the bright lights, I would not be satisfied with just the CAT scan. In the real world, have I ever seen someone who had a CAT scan that I could lay eyes on, that was taking minocycline, that I stopped at that point and watched them get better after taking the drug away? Yes, but I don't think that's a fair thing to recommend to non-experts.
All right. So our next steps, we kind of agreed with the thought process, and so we obtained both MRI and MRV imaging, which after review looked completely normal. A lumbar puncture then was obtained showing an opening pressure of 37 centimeters of water, which is high. All of the cerebral spinal studies were normal. So we talked with the patient. We recommended stopping the minocycline. Based off of her symptoms, we also recommended starting her on acetazolamide and counseled weight loss, even though she was not terribly overweight. At follow-up, all of her symptoms had pretty much resolved, but there was still papilledema and mildly enlarged blind spots on her visual field, so we increased her acetazolamide, and then the following month was looking much better.
Would anyone have deferred the lumbar puncture?
No, stay tuned for, what is it, Monday. We'll discuss that issue.
Would anybody have not ordered the venogram or the MRV?
You know, I mean, I think there's no question that the right way to do it is the way this patient was managed, maybe plus or minus adding the Diamox depending on how the patient felt. But I'd be the first to admit there are times when I veer off the typical flow chart of working up papilledema. I'm sure there are exceptions, and we'll see spectacular cases on Monday where the lumbar puncture revealed something we weren't expecting. You know, but in the end, there are the real life of managing something that you have good instincts about. And so there are times when you deviate from it, but I think if you're an ophthalmologist who's stuck making these kind of decisions because you don't have access to neuro-ophthalmologists, and notice I didn't say general neurologists because they're not very good at this disease and making decision-making, then I think you should play it by the books, which you can. If you have imaging, you have IR-guided LPs, if you tell people what you're looking for, you have a visual field machine and a prescription pad to write Diamox, you can easily manage this patient without vision loss and presumed minocycline-induced papilledema.
One thing, and I'm glad you said presume, because we've all seen patients who were on medications that could cause increased intracranial pressure and a pseudotumor syndrome, a secondary pseudotumor cerebri, if you will, and you stop the medication, you put them on Diamox, they get better, they stay off the medication, you stop the Diamox, and the papilledema gets worse again, and it turns out it was primary pseudotumor cerebri. So just because somebody's on a medication that could cause it doesn't mean it has.
As far as the CT venogram is concerned, that is a lot of radiation. MR venogram without contrast is probably suboptimal too. I have a deal with my radiologist where when we order an MRI scan of the brain for elevated intracranial pressure, they'll do post-contrast SPGR imaging, which gives an amazing look at the veins. And you can really tell quite well whether or not somebody's got a venous thrombosis. They will always have the narrowing at the transverse sigmoid junction where the veins get compressed probably by elevated intracranial pressure. That can be a nice, helpful radiologic feature of high pressure, but that you can get the information in one scan if you play your cards right.
We wrap up, Dr. Lai?
Sure. So there's a few take-home points just to kind of keep in mind that idiopathic intracranial hypertension is a diagnosis of exclusion. So as kind of what we've already discussed, you have to rule out all of these other things. So if you're saying it's papilledema until proven otherwise, you have to rule out brain tumor until proven otherwise, other secondary causes before you can call it IIH. And then there are some pertinent history findings that you need to keep in mind, but even if those things are positive, that does not completely exclude the possibility of something else causing the intracranial hypertension. We also touched a little bit about optic disc drusen or other pseudopapilledema types of cases. It can mimic papilledema and does not completely exclude increased intracranial pressure, and in this kind of case, you should always still consider papilledema until proven otherwise.
Thank you.